Hi everybody, this is Module 6, Part 2, recording number 2. And we're going to start this recording with asthma. So the significance of asthma is that it affects about 20.4 million adult Americans. It is higher, 38% in blacks than whites. Hispanics, especially from Puerto Rico, have higher rates of asthma and age-adjusted death rates than all other racial and ethnic groups. Black females have the highest mortality rates from asthma. 1.7 million ED visits per year from asthma, and the incidence is increasing, but thankfully mortality is decreasing. There are some gender differences to note. Men are more affected before puberty, where women are affected more in adulthood. Women are more likely to be hospitalized, and there is a higher mortality in women. So the pathophysiology of asthma. The main pathophysiological process is an inflammation, so inflammatory process. The exposure to the allergen or irritants triggers the inflammatory cascade, which involves a variety of inflammatory cells. The inflammation does lead to bronchoconstriction, a hyperresponsiveness, and edema of the airway leads to that limited airflow. In the early phase, in that response, in that 30 to 60 minutes after the exposure to allergen or irritant, mast cells are released. Mast cells actually release inflammatory mediators when an allergen cross-links with IgE receptors, which when you think about labs, when we're looking for inflammation, IgE is what we look for. Mediators include leukotrienes, histamine, cytokines, prostaglandins, and nitric oxide. So this picture over here demonstrates the pathophysiology. There is that allergen. It affects the B lymphocyte. It causes the plasma cells to release those IgE antibodies, which then causes the mast cell, the allergens, and then the mast cell releases histamine and the inflammatory mediators, which results in that mucus and the narrowing and all those other things. There are many things that can cause an asthma trigger, and that's one of the big things when you're dealing with somebody with asthma is to help them identify their triggers. So it can be anything from cockroaches, animal dander, dust mites, fungi, pollen, molds. Cigarette smoke is a big one. Wood smoke, vehicle exhaust, concentrated pollution, so you think about like LA and areas that have really high pollution, occupational asthma, food and drugs. GERD is more common in people with asthma, and we'll talk a little bit about that later on. Emotional stress and exercise-induced asthma or exercise-induced bronchospasm. And so that's when somebody has that bronchospasm that is exacerbated by physical exertion. So a little bit more about the asthma pathophysiology. The inflammatory mediators affect the blood vessels and cause vasodilation and increase capillary permeability, therefore that runny nose. It can affect the nerve cells, therefore causing itching, smooth muscle cells, the bronchial spasms and narrowed airway, and goblet cells produce that mucus production. In a late phase response, airway inflammation occurs within 4 to 6 hours after initial attack due to an influx and activation of more inflammatory cells. That occurs in about 50% of patients. Symptoms can be more severe than early phase and can last for 24 hours or longer. Corticosteroids are used to treat inflammation. Unfortunately, with asthma, there can be some structural changes or remodeling from that chronic inflammation. And so changes include fibrosis, smooth muscle hypertrophy, mucus hypersecretion, and angiogenesis. Progressive loss of lung function, not fully reversible, results in persistent asthma. So these are some more pathophysiology things showing you. So again, here we have this triggers, infection, allergen, exercise, irritants, whatever that trigger is, affects that immune activation. So that's that IgE production, which then affects the mast cells. And then both of these affect those inflammatory mediators. As we talked about in the previous slide, that can cause vasodilation, increased capillary permeability, which all affect bronchospasm, vascular congestion, edema formation, mucus secretion, impaired mucociliary function, thickening of airway walls, and then that bronchial hyperresponsiveness and airway obstruction. This cellular infiltrate from the neutrophils, lymphocytes, and eosinophils also affect these. And the neutrophils released with autonomic nervous system effects also affects these. And then these also affect that airway remodeling. So some of those factors that cause the obstruction, the smooth muscles are affected, the swollen mucosa, so that you notice that narrowing, the muscle spasm, and then that mucus. So the mucus plug can definitely, along with all that swelling, can cause people to have obstruction and not being able to move that airway. Actually, not being able to move the air. Now let's discuss the signs and symptoms of asthma. The typical manifestations include wheezing, cough, shortness of breath, and chest tightness. The hyperinflation and prolonged expiration due to the air trapping and narrowed airways are what causes these symptoms. And when you think about the cough, they have that air trapped in their lungs and they're coughing to help get that out. In an acute attack, wheezing is the most common symptom. And it usually starts out with expiratory wheezes, but as it progresses, they're going to have both inspiratory and expiratory wheezes. Now, wheezing is not reliable to gauge the severity of the attack. You have to move air to make the sound. So in a mild attack, they may have loud wheezing. But in a severe attack, there could be wheezing with forced expiration or no wheezing at all. And decreased or absent breath sounds may occur with exhaustion or inability to have enough muscle force for breathing. And so if you have somebody who starts out really loud and all of a sudden you're not hearing breath sounds at all, that silent chest is an ominous sign. So you should really be worried about they could have severe airway obstruction or impending respiratory failure, and that may be life-threatening. So if you have that silent chest, you're going to let somebody know about that right away. Hyperventilation occurs during an asthma attack when the lung receptors react to the increased lung volume due to trapped air and restricted airflow. This results in decreased alveolar perfusion and ventilation, along with heightened alveolar gas pressure, leading to a mismatch in ventilation perfusion, also known as VQ. Early on, the patient may experience hypoxemia with lowered PaCO2 and elevated pH, respiratory alkalosis, due to the hyperventilation. As airflow restriction worsens and air becomes trapped, the patient exerts more effort to breathe. Initially, the PaCO2 levels normalize as the patient tires, but eventually they rise, leading to respiratory acidosis. An increasing PaCO2 level and a declining pH signal the onset of acute respiratory failure, indicating a critical condition. Status asthmaticus is an extreme acute asthma attack characterized by hypoxia, hypercapnia, also known as increased CO2, and acute respiratory failure, and it's very life-threatening. You'll also see chest tightness, increased shortness of breath, and a sudden inability to speak. Without treatment, the patient is going to have hypotension, bradycardia, and respiratory and/or cardiac arrest. At this point, bronchodilators and corticosteroids are not effective. The patient needs emergency treatment. We're going to expect them to have intubation and mechanical ventilation, hemodynamic monitoring, analgesia, and sedation, and they will also be given IV magnesium sulfate. Not only do we need a good history and physical assessment, there are other things that we're going to need to know to determine if somebody has asthma. A peak expiratory flow rate is done by using a peak flow meter, and I have a picture of one right over here. It helps to predict an attack or monitor severity, and we'll talk more about the different. Notice how there's a green up here and a yellow and a red. We'll talk more about that in the next slide. A spirometry is when it checks for lung volumes and capacities. Patients need to stop their bronchodilators 6 to 12 hours prior to, and what we're looking for is to see if there's some reversibility of obstruction once we've given a bronchodilator. That helps us give us that definitive asthma diagnosis. Other things that can be done are allergy testing, obviously pulse ox or ABGs. Chest x-rays are going to help us to rule out other disorders, and a sputum culture and sensitivity will help us to rule out bacterial infection. So as part of the asthma plan, we're going to give them an asthma peak flow meter and an asthma care plan. So you're actually going to have the patient do their peak flow anywhere from 2 to 3 times a day. They should be standing upright, and they're going to take a big deep breath out and blow out as hard and fast as they can. And that's going to give them their best number. So if they are within 80 to 100% of their best, then they are in the green zone and they don't have to worry about anything. If they're in the yellow zone, they're going to have some of those symptoms like coughing, wheezing, chest tightness, or difficulty breathing. Or they may have symptoms with the daily activities such as work, play, and exercise. Nighttime awakening symptoms are a big red flag for that yellow zone. And at this point, we're going to expect their peak flow to be between 50 to 100% of their normal. So actually, that really should say 50 to 80%. So the chart on here is wrong. So yellow is going to be 50 to 80. It's going to end right at that here. And so if somebody is in the yellow zone, we're going to tell them to call their doctor if they've been in that for more than 24 hours. Now the red zone, this person is having severe difficulty breathing, coughing, wheezing, and it's not helped with the medications. They may have trouble walking or talking due to asthma symptoms, and they're not responding to their quick relief medications. And remember in class we talked about those as being our SABAs, such as albuterol. And at this point, the peak flow is under 50%, and they need to call their doctor right away. This type of plan helps to keep people out of the hospital, and sometimes they can't tell that they are having troubles, and so the peak flow meter gives them a better idea of how exactly they're doing. So this image is an image of spirometry where they're testing for that. So notice how they have a plug on their nose, and they're going to be told to take a big deep breath out, and similar to the peak flow, they're going to blow, 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 and they're going to keep telling you to keep blowing even beyond the point that you think there's any air left. And they're going to get those measurements to help them determine if they do have asthma. Next, we're going to talk about mild to moderate attacks, symptoms, and treatment. So with a mild to moderate attack, it's going to be those things that we talked about in the green and yellow zones earlier. So they're not having it more than 2 times a week, minimal interference with ADLs, alert and oriented, speaks in sentences, may have some chest tightness and dyspnea, may have some increased use of asthma medication such as albuterol, but their oxygen saturation is greater than 90% on room air, and their peak flow is going to be at least greater than 50% predicted or personal best. Now, treatment for this is going to be inhaled bronchodilators and oral corticosteroids such as prednisone. We'll monitor vital signs, and this will be monitored as an outpatient unless they're not responding to the treatment or there's some other contributing factor. And afterwards, they'll be following up with their healthcare provider. Now, with a severe attack, they're going to be alert and oriented, but really focused on their breathing. They may be frightened or agitated, specifically if they're hypoxemic. We're going to see those tachycardia and tachypnea. And at this point, we're looking at those respiratory rate of greater than 30. And if you think about breathing every other second, that is a really rapid rate. They're going to be using accessory muscle use, might be sitting forward kind of in that tripod position, wheezing, and their peak flow is going to be less than that 50% predicted or personal best. And they're having recurring symptoms that interfere with their ADLs. With a severe attack, we're going to expect them to go to the ED and then be admitted. They may need supplemental oxygen and oximetry. PaO2, we're going to try and keep that greater than 60 and SaO2 greater than 93. Monitor the peak flow, ABGs, and vital signs. We're also going to be giving bronchodilators and oral corticosteroids, although sometimes they'll even do the IV steroids. And if there's a silent chest, immediately notify the healthcare provider. Let's talk about asthma medications. Quick relief or rescue medications help to treat those acute attacks. Bronchodilators, also known as SABAs, short-acting beta agonist, are one of the things that all patients should have. They may also be prescribed inhaled anticholinergics, and one of those is called Atrovent, is the trade name. The generic name is ipratropium. Anticholinergics help to decrease secretions, so that's why that would help. Other medications include anti-inflammatory medications such as IV corticosteroids if they're in the hospital. Otherwise, they might be getting the prednisone at home. And the SABAs, as I mentioned, albuterol is an example. It helps to stimulate the beta-2 receptors in the bronchioles to help produce bronchodilation. It's very effective for relieving that acute bronchospasm with an acute attack. Onset is within minutes, and it can last up to 4 to 8 hours. Short-acting beta agonists help to prevent release of inflammatory mediators from the mast cells, and so that's one of the reasons you would take that prior to exercise to help prevent that attack. Now, on here it says too frequent use can cause tremors, anxiety, tachycardia, palpitation, and nausea, but many of those are typical side effects that patients do have with bronchodilators, and we don't want to be using those over and over for long-term use. Long-term control medications help to achieve and maintain control. Bronchodilators such as long-acting beta agonist, LABAs, methylxanthines, anticholinergics, that ipratropium that I talked about, can be used as a acute or a long-term. Anti-inflammatory medications such as oral or inhaled corticosteroids, leukotriene modifiers, and anti-IgE. Now, a LABA, there are a couple examples, salmeterol and formoterol. Notice those look similar to albuterol, so it is very important that you memorize these medications because it's really important to teach a patient not to take their salmeterol or formoterol with an acute attack. They may also have inhaled corticosteroids as a combination with the LABA, and these are used once every 12 hours and help to decrease the need for a SABA. Methylxanthines are a class of medications that aren't used as much. Theophylline is an example. It is less effective than a long-term bronchodilator, and it's used only as an alternative. Prior to having LABAs, this was the medication we use. There are many drug interactions and side effects. The action's not exactly known, and there is a narrow margin of safety. They have to have their blood levels monitored, and if they do have theophylline toxicity, the symptoms will be nausea, vomiting, seizures, and insomnia. Corticosteroids help to reduce bronchial hyperresponsiveness, blocks late phase response, and helps to inhibit migrations of inflammatory cells. Most effective long-term control drug. Examples are beclomethasone and budesonide. Oral corticosteroids are usually used for 1 to 2 weeks for that maximum effect during a severe chronic asthma attack. Inhaled corticosteroids are used for a long-term control on a fixed schedule, and they're usually used once a day. There's little systemic absorption except for high dose with the inhaled corticosteroids, and they can cause easy bruising and reduce bone density. And when I think of reduced bone density, I'm thinking of osteoporosis. Now, local side effects from the oral or the inhaled corticosteroids are going to be oropharyngeal candidiasis, hoarseness, and a dry cough. It can be reduced by using a spacer or by gargling after each use. And anytime somebody does an inhaled corticosteroid, they should minimally be rinsing their mouth out and gargling, if not brushing their teeth. That will help to prevent them from getting that oropharyngeal candidiasis. Leukotriene modifying agents are also medications that can be used for long-term control. Examples are xerilucast, montelukast, and xylulin. These are all administered by mouth. It helps to interfere with synthesis or block the action of the leukotrienes, which helps to produce both a bronchodilator and anti-inflammatory effect. Again, this is taken for prophylaxis and maintenance, not for an acute attack. Monoclonal antibody or anti-IgE. An example is omalizumab. It helps to reduce circulating IgE levels, and it prevents IgE from attaching to mast cells, preventing release of chemical mediators. This is given subcutaneously every 2 to 4 weeks for moderate to severe asthma, and they have to get this actually at the physician's office, and they have to stay to be monitored because of the risk for anaphylaxis. These patients will also need to carry an EpiPen with them. MDI, it is a meter dose inhaler, and this is what it looks like. That can be your albuterol or ipratropium. It does have a propellant that helps to get it out, and it can be used with this spacer. And so notice this spacer. The spacer helps to reduce the oropharyngeal medication deposit, actually meaning less of it on your tongue or in your mouth. Therefore, it's increasing the delivery into the patient's lungs. And there are some people that just have troubles with that hand-breath coordination. So with a spacer, they're able to hit that button and then breathe in and out a couple times through the spacer, and they're going to get much more of the medication. Now, this is an example of a DPI, a dry powder inhaler. And so this is, they actually move this little lever over here, and it activates the next time for them to be able to take a breath. It is breath activated. The advantage over an MDI is that you don't need that dexterity or inhalation coordination, and you don't need a spacer. The disadvantage is if you don't have adequate inspiration, you're not going to get as much of the medication. Not all common meds are available as DPI, and the powder may clump. Personally, I hate how it feels in my mouth when I've done a DPI. I actually prefer the MDIs personally. Now, nebulizers are machines that help to convert drug medications that are in solutions into a fine mist for inhalation, either through a face mask or a mouthpiece. It does require an air compressor or an oxygen generator, and you do have to do some education for technique and care. Common medications that can be used by nebulizer are albuterol or even the ipratropium, or even a combination of the two. So as I mentioned earlier, we really want to help our patients to identify those triggers so that they can stay away from them. They're going to want to stay away from those irritants. They can use scarves or masks for cold air. That's another one of those things that are often triggers. They want to avoid aspirin and NSAIDs. They want to make sure that if they have an upper respiratory infection or sinusitis, that they are getting a prompt diagnosis and treatment for those. They want to monitor for weight loss, continue to have a fluid intake of that 2 or 3 liters every day. And again, as we've talked about this before, like with pneumonia, this helps to thin secretions. Want to make sure that they're getting good nutrition, adequate exercise, and if they are going to be getting, actually that should have been adequate rest, and if they are going to be exercising, they need to have a pre-treatment plan if needed. Not all patients who have asthma have exercise-induced asthma. So this is the same thing that we already did with that action asthma plan where we had the red, green, and yellow. And so this is green. Again, they don't have symptoms. Their peak flow is at least 80 or higher of their personal best, and they're just going to remain on the medications. Again, in the yellow zone, asthma is getting worse. They are symptomatic. They're able to do some activities, but not all. And our peak flow is going to be between that 50 and 79% of personal best. Whereas with that red action plan, it is a concern. They are symptomatic and medications are not helping. They cannot do their usual activities, and their peak flow is going to be 50% or less from their personal best. They need to either call their physician, call an ambulance, or get to the hospital to make sure they don't have any complications. So when you care for somebody who is in the hospital with asthma, we're going to obviously want to monitor their respirations and cardiovascular systems, listening to their lung sounds. Remember, wheezing may get louder as airflow increases. Heart rate and rhythm, respiratory rate, and work of breathing, we're looking for those accessory muscles. Monitoring their blood pressure. We'll be monitoring pulse oximetry, peak expiratory flow rates, and ABGs potentially. We'll give medications as ordered, and then it's really important that we evaluate their response to therapy. It may take several days before they start improving. An important goal of nursing is to decrease the patient's anxiety and sense of panic. Remember, if the patient can't breathe, it's scary. So we're going to make sure we position them comfortably, semi to high Fowlers, use talking down to keep calm, coaching them to use that pursed lip breathing, stay with the patient, and after an attack subsides, make sure that you allow them to rest. If you can't get that history and physical done when they first come in, let them get their breathing under control and then finish that H&P later. Some of the expected outcomes for somebody with asthma. We want to make sure they maintain that patent airway and they're able to remove their secretions. We want them to have normal breath sounds and respiratory rate. Hopefully they're going to report decreased anxiety as the control of the breathing improves. They need to be able to demonstrate correct use of the medications, and they need to express confidence and ability to manage asthma. I will do the next recording for asthma as a separate recording since this one is already so long.